Welcome everyone to the presentation about the study in which we assessed the association between bariatric surgery and Dupuytren disease. For some reason, I cannot move to the next slide.
Try clicking on it and then page.
Here we go. So there are no disclosure of interest. So Dupuytren disease is a rare hand deformity caused by a thickened and tightened fascia, and the exact etiology is unknown. For example, obesity was suggested to decrease the risk of Dupuytren. And risk factor of Dupuytren include male sex, older age, uncontrolled diabetes, and Northern European ethnicity. So what happens if a patient undergoes bariatric surgery and loses substantial amounts of weight? There is no literature on this association, and therefore we assess the association between bariatric surgery and Dupuytren disease. We performed this study in a nationwide Swedish healthcare registry between 2006 and 2019. We performed a sequential cohort study in which we matched our bariatric surgery patients to up to 2 patients with obesity only, and we did so on the propensity score. For the propensity score estimation, we used around 30 variables, including demographics, confounding factors, and also factors associated with obesity, factors associated with undergoing bariatric surgery and surgery in general, as well as risk factors of Dupuytren disease, such as hand trauma. As I mentioned before, our exposure were first-time bariatric surgery patients aged 30 to 79 years, and our only exclusion criteria was a previous Dupuytren. Our outcome was defined as a first diagnosis of Dupuytren or Dupuytren surgery. Follow-up started only after a 1-year running period, and we followed patients until the outcome or censoring due to development of an exclusion criteria, change of exposure status, loss to follow-up, or end of study period. We performed Cox proportional hazard regression analysis, and we performed subgroup analysis by age, sex, bariatric surgery type, duration of follow-up. In a sensitivity analysis, we performed asymmetric trimming of propensity score tails. To briefly mention what the sequential cohort design is about. So we just dissected our study period into blocks, and each block gave rise to a cohort. And within these blocks, we matched our bariatric surgery patients to up to 2 unexposed patients. And we did this to give the exposed and unexposed patients the entry within a similar time window to somehow assess, to control for these potential time trends. And we performed our analysis after combining all cohorts into one. So we did not do the regression analysis per block. Here you see the patient's characteristics before propensity score matching, and you see that the unexposed patients, they were quite older, and that the exposed patients, they had a higher number of hospital contacts, but also that the unexposed patients had a higher proportion of metabolic and cardiovascular diseases, and only that the exposed patient had a higher proportion of the gastroesophageal reflux disease, which is also an indication for bariatric surgery. We matched around 80% of our exposed patients to unexposed patients, and the covariate balance was achieved. You can see this through the z-statistics of 0.57. And also when we assessed the standardized mean difference, we saw that all covariates were nicely balanced. In the propensity score match cohort, here you see among the exposed patients the body mass index at bariatric surgery and 1, 2, and 5 years after, also stratified by surgery type. And the blue and the gray line, they almost are the same because the majority of patients had a gastric bypass. And you can see that the sleeve gastrectomy patients in the orange line slightly lost less weight, and that the duodenal switch were the biggest at the beginning and also lost the most weight because it's the most drastic surgery. In total, we had 126 Dupuytren cases among bariatric surgery patients and 136 among unexposed patients. If we look at the hazard ratio, we see a 30% increased risk overall. We see that this increased risk was mainly in women and not found in men. For age groups, there was no difference between younger and older patients. In bariatric surgery subgroup, we did not have enough cases in the duodenal switch group, so there is no hazard ratio here. And you can also see that the sleeve gastrectomy patients did not have an increased risk. However, the gastric bypass patients had an increased risk of Dupuytren disease. In subgroup of follow-up, we see that only after more than 5 years of follow-up, we see this increased risk of Dupuytren disease. And when we trim the propensity score, we see that this emphasizes our observed overall results. For strength, we can say that we had nationwide Swedish registries with almost a complete follow-up, and that the propensity score matching yielded highly comparable groups. However, we did have limited sample size because Dupuytren is a rare disease, and we did not have BMI measurements in patients without bariatric surgery. However, we tried as best to come to control for this through the propensity score matching. So to conclude, we say that substantial weight loss is associated with a latent increase of severe Dupuytren in an obese population. And this observation further strengthens current evidence that high body mass index is protective against Dupuytren. And the latency of this risk increase after bariatric surgery may suggest that slowly adapting metabolic changes may be part of the mechanism of Dupuytren emergence. So this study is not really a safety endpoint study, as the title may suggest, but since the prospect of developing Dupuytren disease after bariatric surgery should not discourage someone from going under bariatric surgery. And this research is more into the disease mechanism. So I thank all Swedish patients contributing to their data in the Swedish nationwide registries, and that we could use the Scandinavian Obesity Surgery Registry for this research. Furthermore, I thank all my co-authors from UK, Sweden, and Switzerland, and also the Swiss National Science Foundation, which funded me with a research day to perform the analysis in Stockholm, and Professor Lagergren for hosting me in his research group. And I thank you very much, and I'm looking forward to questions.
Thank you, Teresa. Thank you for your presentation. It is very nice work. There is one question from Dr. Xie. He asked, in consideration of the relative low incidence of the outcome, have you considered PS weighting in order not to lose too much sample? Could you please answer for the questions?
Yeah, that's a very good point, actually. We could match 80% of our patients, and we also did the 1-to-2 matching instead of the normal 1-to-1 matching to get to increase our power. But I agree that weighting may have been also a very good choice to slightly increase our outcomes.
Yeah, and if you use overlap weighting, you might not have that strong influence of the extreme values. So IPTW with overlap weighting is something to be considered too. I had a question. This is Cindy Gurman. I wondered if you had seen, if you looked at the potential, I know you combined all the cohorts together that were defined over the years. Did you look at any temporal trends or anything to see if that was appropriate?
I didn't do it, and I was thinking about it, but again, maybe the sample size may have limited our interpretation from these individual cohorts.
Yes, yes. Okay.
Cindy, I have another question. In terms of risk-benefit ratio, do you think the benefit owing to bariatric surgery and the risk due to Dupuytren disease, what's your opinion for this issue?
Yes, as I mentioned in my conclusion, it's more really to give insight into the disease mechanism, which is not entirely clear. So it was, I mean, obesity was shown to be protective, but we were not sure whether then weight loss would actually be a problem. So this was more to add more insight into the mechanism, and also that we see only this latent increased risk. So it may really show that the metabolic changes may be contributing to the disease.
I believe we need to go on to our next speaker. Thank you very much
Thank you.
for that presentation. Our next speaker is Dee Thao, I believe from McGill University, speaking on selective serotonin reuptake inhibitors and the risk of type 2 diabetes mellitus in youths. Go ahead.
Hello, everyone. Thank you for being here. And I would also like to thank ISPE for the opportunity to present today. Can you see my screen?
Yes, we can.
Okay. So let me get started. We have no disclosure of conflict of interest related to this study. And a little bit of background. Selective serotonin reuptake inhibitors, or SSRIs, are commonly prescribed in youth, and there's been emerging evidence suggesting an association between type 2 diabetes and SSRIs in this population. However, the studies that have done so far looked at SSRIs as a class, so whether the risk of type 2 diabetes varies between SSRIs is unclear, and this is a clinically useful information to know when SSRI is indicated. With respect to the potential pathway from SSRIs to type 2 diabetes, the binding affinity of SSRIs to several receptors, 5-HT2C, H1, and serotonin transporter or SERT, has been associated with weight gain and insulin resistance in adults, suggesting pathway to type 2 diabetes. And as you can see on the graph in the right, the 6 SSRIs, escitalopram, fluvoxamine, paroxetine, sertraline, citalopram, and fluoxetine, have similar affinity to SERT, which is the blue line, and but variable affinity to H1. And you can't really see 5-HT2C on the graph, but the idea is similar. Therefore, the objective of our studies is to assess whether the use of SSRI with stronger affinity for 5-HT2C and H1 relative to SERT is associated with higher risk of type 2 diabetes compared to weak affinity SSRIs. We use data from the Clinical Practice Research Data Link in the UK, which is a primary care database with more than 50 million patients from over 2,000 practices. The data is representative of the UK in terms of age and sex, and prescriptions are automatically transcribed in the database, ensuring that prescription data is complete and accurate. Our cohort consisted of patients aged 5 to 24, newly prescribed a strong affinity SSRI, so citalopram, escitalopram, and fluoxetine, or weak affinity SSRI, paroxetine, sertraline, or fluvoxamine between 1990 and 2019. Follow-up starts from the date of first prescription, and we excluded patients with less than 1 year of data in the CPRD, patients with a history of antidepressant prescriptions, or patients who were prescribed 2 antidepressants at cohort entry. We also excluded patients with existing diabetes, so type 1, type 2, gestational, people with impaired glucose tolerance, or with polycystic ovarian syndrome, which might be indication for metformin, and any other anti-diabetic medication. Follow-up ends at the diagnosis of type 2 diabetes, discontinuation or switch to another antidepressant, end of registration with the practice, end of study period, death of any cause, or a diagnosis of type 1 diabetes, gestational diabetes, polycystic ovarian syndrome, or prescription for insulin. We used it an as treated exposure. So patients were considered exposed from the first prescription to discontinuation or switch to another SSRI of the other binding categories, so strong to weak binding and vice versa, or an antidepressant that is not an SSRI. Duration of use was calculated within the same binding category. So 2 overlap prescriptions means that patients were continuously exposed, or when 2 successive prescriptions did not overlap, then we allow for a 90 days grace period for refills, residual effect, and delayed diagnosis. Outcome of incident type 2 diabetes was ascertained with a diagnosis code for type 2 diabetes, a prescriptions for an antidiabetic that is not insulin, or a code for diabetes not otherwise specified, and no insulin prescriptions in the next 90 days, with type 2 diabetes set at the end of this 90 days. We had more than 30 covariates measured at or before cohort entry, including age, sex, lifestyle factors, psychiatric visits, comorbidities, and medications. We control for confounders using standardized mortality ratio weighting, in which the weight of the strong affinity group was set to 1, and the weight of the weak affinity group or the reference group was set to the odds of treatment probability, which in this case is propensity score over 1 minus propensity score. And in doing this, we reweight the propensity score of the whole population to be representative of that in the treated population. And we also use calendar time specific propensity scores, in which we calculated separated propensity score distributions for each 5-year calendar band, so 1990 to 1994, so on and so forth, instead of over the whole study period. And doing this method allows for better control of changing prescription over time, trends in type 2 diabetes incidence, and other possible heterogeneity in covariate distributions, since we have a 30-year study period. Our primary analysis was a weighted cost proportional hazard models, in which we calculated the hazard ratios of type 2 diabetes with 95% confidence interval, comparing strong and weak affinity SSRI. We have 3 secondary analyses: duration of use, so less than 120 days, 120 to 40 days, and more than 240 days. We also repeated the primary analysis stratified by age, sex, BMI, prior antipsychotics use, which is an independent predictor of type 2 diabetes risk, and prior psychotropic use. We also compared fluoxetine, strong affinity, versus sertraline, weak affinity, since these were the 2 most commonly prescribed SSRIs in youth. Sensitivity analysis, we had 5 different ones. So varying grace period to 60 or 120 days. For exposure, modifying the definition by additionally censoring people who switched to SSRIs of the same binding category, restricted the outcome definition to either 2 type 2 diabetes diagnosis within 180 days, or 1 type 2 diabetes diagnosis and another diagnosis for diabetes not specified, or a prescription for non-insulin antidiabetic within 180 days. We also censored type 2 diagnosis within the first 30 days of cohort entry, since these diagnoses were unlikely to relate to use of SSRIs. And finally, we considered an analysis analogous to intention to treat, in which patients were considered exposed until the end of follow-up with a maximum of 1 year. So for our results, we had about 347,000 new users of strong affinity SSRIs, 131,000 new users of weak affinity SSRIs, and after weighting, covariates were well balanced between groups with a standardized mean difference of less than 0.05. The majority of patients in our cohort were female, 65%, age 19 to 24, 75%. As you can see, there is no difference in the risk of type 2 diabetes for strong SSRI versus weak SSRIs, with a adjusted hazard ratio of about 1.03. And similar for across our secondary analysis. However, as you can see on the graph, there is a numerically higher risk for patients with low or normal weight BMI, patients with prior antipsychotic use, and patients with prior psychotropic use. However, the confidence interval for all these estimates still include 1. And finally, our sensitivity analysis also suggests no difference across the modified definitions and analysis that we use. Therefore, we concluded that strong affinity SSRIs are not associated with an increased risk in type 2 diabetes compared to weak affinity SSRIs in youth. The null results were consistent across secondary and sensitivity analyses. Therefore, if an SSRI is indicated, then these findings should provide reassurance that there's no difference in risk of among the SSRIs that could be prescribed to children and adolescents. Thank you.
Thank you for that presentation. And this paper is now open for some discussion. If you have any questions, please put them in the Q&A or in the chat. So I see that there is one question posted in the Q&A from Taiwan. It often takes a few weeks for a patient to find his own suitable antidepressant. Is this an issue for follow-up, or how long was the median follow-up?
Thank you for the question. So we did calculate the median follow-up, which was about 146 days, and interquartile range was 118 days to 251 days. And this was very similar for both users of strong and weak affinity SSRIs.
I had a question as well. How accurate do you think incident type 2 diabetes is in youth? Is there like a typical screening that's done for type 2 diabetes that where blood sugar and or HbA1c is collected on a routine basis?
Oh, thank you very much for the question. Yes, that is definitely a problem that the use of the database might have limited us, because this is not a research database. So the prescriptions were accurate because it was automatically transcribed, but diagnoses were not entered at the same time. So we had to infer. And also that's why we needed to do several sensitivity and secondary analysis with varying restricted outcome definitions, like not only one type 2 diabetes code, but two, and we modified it several ways. But the results were consistent. Therefore, even with that a standardized way to diagnose type 2 diabetes, we think that the results are fairly, I don't want to say accurate, I'm not sure if that's the right word, but consistent with the method that we came up with.
But you still could have maybe missed some patients because there's not routine screening.
Yeah.
There's one more question in the chat. Could you please explain why you chose as treated as your main analysis instead of ITT? Is there any possibility of informative censoring?
Yeah, so we chose as treated because of the short duration of follow-up. However, we also, as I explained, we also conducted an analysis analogous to ITT. It's not exactly ITT, for the precise reason of informative censorings. And as I shown in the graph, the results were similar as well.
Any other questions? If not, I had one more.
There one more question from chat.
Okay.
Eugene Wang.
Okay.
Yeah, she asked, can you elaborate more about how BMI variable was assessed, especially in young children?
Oh, thank you for that. So we actually needed to calculate two different ways for BMI, because in children and adolescents, BMIs were calculated based on the percentile with their age and sex group, whereas in adults, that it's the regular one that we all use. And yes, thank you, Jenny. Jenny actually sent me a publication. And yes, I forgot to mention, but we did consulted the Jenny study, and I think one other one that also presented at ISPE a few years ago by Dr. Burku also looked at the same type 2 diabetes risk with children and adolescents. But we were wondering if it So the results of Jenny's study and Dr. Worku's studies were that risk of type 2 diabetes in people who use is higher than people who didn't, or like former versus current. But now we looked at within all of the people who use, then strong affinities are not differentiated related to higher risk compared to use of weak affinity SSRIs.
Thank you. And I had one more quick question, and that is, did you have family history of diabetes?
Oh, that is a very good point. We actually did not, because I think that information was not collected in the database, or at least like not consistent and validated. But we do include it like comorbidities and medication and lifestyles.
Yeah. Thank you. Any other questions? I think we can go on probably to the next speaker, Judy.
Yeah, thank you, Cindy. Our third presenter is from National Chang Kung University, Taiwan, Stephen Chin Yao Shan, and he will present about the risk of venous thromboembolism receiving tofacitinib in Taiwan. Stephen, please start.
Okay, and so everybody can hear me?
Yes.
Okay, wait a moment. Hey, gosh. Oh gosh.
Can we help you in any way?
My computer is something wrong with my computer.
Maybe we could move to the next one and you can reboot. We can add you at the end. Does that sound?
That sounds fine. Why don't you try to resolve it? We'll go on to the next speaker.
Okay, but please go on the next speaker first.
Okay. And Jenny looks like she's ready. So we will. The next speaker is Jenny Sun from, I believe from Harvard Pilgrim Healthcare Institute. And she'll be speaking on risk of type 2 diabetes among children and initiating anticonvulsant mood stabilizers, application of a target trial approach. Go ahead, Jenny.
Hi, everyone. My name is Jenny Sun. Thank you for that introduction. On behalf of my co-authors from Harvard Medical School and Harvard Pilgrim Healthcare Institute, I will be presenting on work titled Risk of Type 2 Diabetes Among Children Initiating Anticonvulsant Mood Stabilizers, Application of a Target Trial Approach. Here are our disclosures. I am currently an employee at Pfizer, but all aspects of the work presented today were completed prior to my employment at Pfizer. As you can see from this figure here, the prevalence of type 2 diabetes in adolescents and young adults has been increasing over time in the US and globally. And these trends are particularly concerning because kids diagnosed with type 2 diabetes are at a higher risk of diabetic complications. And there are so many risk factors for type 2 diabetes, but unfortunately, many of them are difficult to modify. This includes family history, lifestyle factors, and environmental factors. But one risk factor that might be more amenable to change is the choice of which prescription medication to initiate. One group of drugs with limited evidence on the risk of type 2 diabetes are anticonvulsant mood stabilizers. These drugs are used to treat conditions such as bipolar disorder and epilepsy, and many patients receive mood stabilizer treatment across the life course, many initiating during childhood. And while these drugs are known to be associated with weight gain, the effect on type 2 diabetes remains unknown. So in other words, it's unclear whether the amount of weight gain is sufficient to further elevate one's risk of developing type 2 diabetes. A randomized trial, unfortunately, does not exist to answer this question, so we must rely on non-randomized studies to generate evidence. This study will apply the target trial approach proposed by Miguel Hernan and Jamie Robbins, which is a framework for conducting non-randomized studies when a randomized trial is not available. The idea behind this approach is that investigators should explicitly outline the description of the hypothetical target trial that they would like to conduct, then emulate this trial as closely as possible within observational data. And by doing this process, investigators can help avoid common methodological pitfalls of observational research, such as the misalignment of baseline or time zero. And I think this framework is especially helpful when studying medication safety in children, because children are often excluded from RCTs. Therefore, we must rely on non-randomized studies to guide treatment decision-making in the pediatric population. So the objective of this study is to evaluate the comparative safety of anticonvulsant mood stabilizers on the risk of type 2 diabetes in children and adolescents by applying the target trial approach. Step 1 is to conceptualize the hypothetical pragmatic trial that we would have liked to conduct. I'll briefly walk through each component of this hypothetical target trial. In our ideal pediatric trial, we would enroll patients aged 10 to 19 years old and then impose the following requirements: at least 1 year of continuous enrollment, as well as no previous dispensing of an anticonvulsant medication, no diagnosis of diabetes, no evidence of pregnancy or bariatric surgery, all during the prior year. Children would then be randomized to receive one of 4 treatments: carbamazepine, lamotrigine, oxcarbazepine, or valproate. In the trial, treatment adherence would be defined as daily adherence to the assigned treatment. Children would be followed until the outcome of type 2 diabetes, trial disenrollment, or 5 years after baseline. We would then estimate the intention to treat effect, which estimates the effect of initiating baseline treatment, and the per protocol effect, which estimates the effect of initiating and continuing baseline treatment. We would analyze the data by generating survival curves stratified by treatment group. In the per protocol analysis, we would additionally censor patients when they deviate from their assigned treatment strategy. And what I mean by that is we would impose 2 additional censorship events: treatment discontinuation and a treatment switch. Then we would use inverse probability of censoring weights to account for the factors associated with adherence. Step 2 would be to emulate the target trial in real-world data. This trial was emulated within the MarketScan commercial claims database. The eligibility criteria for the emulation was the same as for the target trial. The treatment strategies in the emulation were approximated using dispensing data from the claims. The date of the first prescription filled served as the index date, or the initiation date, and treatment adherence was assessed using a treatment diary constructed from dispensing dates and day supply. The reference group for the analysis was lamotrigine, which is a mood stabilizer that is known to be weight neutral. So as a reminder, the other mood stabilizers are thought to be associated with weight gain. Now, treatment assignment is really the main place where our emulation differs from the target trial. We do not have the ability to randomize patients. So instead, we must emulate randomization by applying inverse probability of treatment weights to account for baseline confounding. These weights were estimated using multinomial logistic regression. The outcome and the follow-up period in the emulation were the exact same as for the target trial. The outcome was defined in MarketScan based on a previously validated algorithm that had strong performance in a pediatric population. In this emulation, we estimated the observational analog of the intention to treat and per protocol effect. And finally, the analysis plan is the same as for the target trial, except now we must account for baseline confounding. Then we use weighted pooled logistic regression models to estimate treatment effects. Here's an overview of the study cohort included in the trial emulation. As you can see from this table here, across the 4 different treatment groups, patients differed slightly across a range of characteristics. But after weighting by the inverse probability of treatment, patient characteristics were similar across the treatment groups. And that's exactly what we wanted to. IPTW helped us emulate randomization in an RCT as best as we can. Here's a weighted survival curve from the intention to treat analysis. On the x-axis reflects time in years, and the y-axis reflects the probability of remaining free of type 2 diabetes. We can see that initiators of valproate, shown in purple, are at a higher risk of developing type 2 diabetes compared to lamotrigine initiators, shown here in blue. This corresponded to about 2 additional type 2 diabetes cases per 1,000 initiators over the 5-year follow-up period. Initiators of oxcarbazepine, shown here in green, also had a higher risk of type 2 diabetes compared to lamotrigine initiators. And here are the findings from the per protocol analysis. Unfortunately, the per protocol analysis was underpowered. After censoring patients at the time of treatment discontinuation or treatment switch, we observed substantially shorter follow-up time with a mean of only 6 months and very few type 2 diabetes events. This analysis had generally similar findings as the intention to treat analysis, but we were unable to detect meaningful differences in type 2 diabetes risk across treatment groups. Therefore, larger studies are needed to confirm these findings. To summarize, in this non-randomized emulation of a pediatric trial, the choice of which anticonvulsant mood stabilizer to initiate may have meaningful reductions in the incidence of type 2 diabetes. We found that children initiating valproate may be at a small increased risk of developing type 2 diabetes compared to lamotrigine initiators. And patients who may be concerned about these potential risks of type 2 diabetes may consider treatment with lamotrigine, a weight-neutral mood stabilizer. And even though this study is just one example of how we can expand the evidence base in the understudied pediatric population, we found that in the absence of randomized trials, emulating trials within healthcare databases has the potential to generate the age-specific drug safety data that are needed to inform treatment decision-making. And I think that is great news for children, their parents, and their providers. I want to end by acknowledging the incredible team involved in this project, especially Jason Block. And to thank you all for coming today and listening. I have left my email address here, so feel free to let me know if you have any questions, comments, or suggestions.
Thank you, Jenny. That was a nice presentation. While we wait for people to put in questions, I did have a question about your derivation of the propensity scores. How did you do that with the 4 different treatment groups? Did you do it pairwise, or did you use an approach that to model it so that you could have the same population across?
That's a great question. So because we thought of this comparative safety as ultimately the patient has 4 options to pick from. And so we modeled it with a multinomial regression with lamotrigine as the reference group in the propensity score. So if we had instead done multiple pairwise comparisons, we would have been conceptualizing multiple decisions where the patient's only deciding between, say, carbamazepine and lamotrigine. We felt that actually the scenario where you're comparing all 4 simultaneously is closer to what a patient would actually experience when deciding which one to initiate.
You do have some strong assumptions there. You might want to look at a paper by Lopez and Gutman. They have an approach using, I think, GEE, where they are estimating propensity scores for the pairwise, but they somehow constrain it so that you have the same population. It's not differing across the different, pairwise comparisons. So it might be worth looking into. I came across it a few years ago in a session sort of like this.
Thanks for the
So,
suggestion.
yeah. Any other questions for Jenny Sun? I wondered if you could comment, since we have a little time, on just a couple of minutes on the computable phenotype in kids for type 2 diabetes.
Sure, it's a great question. So we used an algorithm that was published in PDS, I think in 2019, which basically validated a wide range of different algorithms for identifying type 2 diabetes and reported on the best report based on PBV, I guess. To my memory, I think it first identifies kids who have diabetes regardless of type based on an inpatient diagnosis, at least 2 outpatient diagnoses, or an outpatient diagnosis and an oral anti-diabetic. Then from there, they sort into type 1 or type 2, sort of based on like the ratio of diagnosis codes for type 1 versus type 2, the medications that are dispensed. And my understanding is that the best performing algorithm in kids was pretty similar to one published, I think, in adults 2013 with
Okay.
Mike Klompus and Diabetes Care. So
Yeah,
it actually ended up
my
being
question was going to be
yeah, so it's pretty similar to one that's pretty well established in adults.
Okay.
I just think
Okay.
extra attention on the separating type 1 and type 2 in kids.
Yeah, absolutely. Okay, I think we can go on to our next speaker.
Stephen, did you prepare? Have you prepared now?
I let me try it.
Yeah. Oh, yeah.
Yes.
Okay. So this time you can see my screen, right?
Yes. we
Yeah,
can.
yeah. So I already introduced about you. So Stephen, could you please start your presentation?
Okay. And hi everyone, I'm Stephen Shen from Tainan, Taiwan. And today I want to share my research about comparing the risk of venous thrombosis and embolism in Taiwanese rheumatoid arthritis patient between those receive tofacitinib and TNF inhibitors. My advisor is Edward Lai. So we do not have any conflict of interest here. So rheumatoid arthritis is an autoimmune disease that will cause the patient joint pain, swelling, or even deformation. And in this patient, we found, based on previous study, the risk of VT in this patient were about doubled comparing with the health population. And the higher disease severity will have a higher risk of venous thrombosis and embolism. And in this patient, we will use a disease-modifying anti-rheumatoid drug, briefly called DMARD. And in our study, we will focus on TNF inhibitor, which is a kind of biological DMARD, B-DMARD, and the tofacitinib, which is a kind of target synthetic DMARD, TS-DMARD. And in Taiwan, that tofacitinib was approved in 2014. However, in 2019, FDA approved the box warning about increased risk of blood clot and death. And this is based on a post-marketing clinical trial, which majorly include the Western population, Western patient. But we know that the risk of the general risk of VTE in Asian population is just 1/7 or even 1/10 of the Western population. So we are considering that the phenomena we observe in the post-marketing clinical trial will be also observed in our real world situation and in Asian population. So we want to know that we conducting this comparative study between tofacitinib and TNF inhibitor in Taiwanese population. So this is a retrospective cohort study. We use a new user design with the active comparator. We use a Taiwan National Health Insurance database from 2002 to 2018. We include the RA adult patient with any records of tofacitinib or TNF inhibitor. The study outcome is the inpatient records of the venous thromboembolism, which include the deep vein thrombosis and the pulmonary embolism. And after we include this patient, if the patient have the incorrect sex or the history of the malignancy, HIV, or other autoimmune disease, we will exclude them. And if they have any record of rituximab use before the index day, we also exclude them. So after that, we will separate this patient into tofacitinib ever user and the TNF inhibitor user, and did the grading match by age, sex, and number of the B or TSD marks types before the index day. And this is a 1:1 grading match. And after that, we'll do the further analysis. So the index day will be the index day is the first day of tofacitinib or TNF inhibitor use, and we will observe the exclusion criteria in a 1-year period before the index day and also the covariates. We also calculate the number of the B or TSD marks types before the index day. After the follow-up period, the patient will be censored at the VTE event happened, death, or the last day of the database. Our covariates include the RA-related medication use, VTE risk factors, and some comorbidities and co-medications. We will calculate the incidence rate and compare baseline characteristic and drawn the cumulative incidence curve. Our main analysis is to calculate the hazard ratio by conditional proportional hazard model. And we will calculate the crude hazard ratio and the adjusted hazard ratio by IPDW and SMRW. The first sensitivity analysis is to include the outcome from both inpatient and outpatient claims records. And the second sensitivity is to adjust our study period to enroll only patient after 2014. So there are about 70,000 patients in our included in our study, and 13,600 patients will be was excluded. And after that, they have 2,000 patients in tofacitinib group and about 11,000 patients in TNF inhibitor group. After the grading match, there are 1,969 patients in each group. So due to the grading match, the gender and the age and the number of B or TSD marks before the index day is quite identical between two groups. And in co-medication and comorbidity, they are quite similar between two groups, except the ischemic stroke, beta blocker, CCB, and BZD use. So in our result, we found that they have only 6 cases of VTE in tofacitinib group and 22 cases of VTE in TNF inhibited group. And the incidence rate is around 0.18 and 0.22 per 100% years in these two groups. And no matter the crude hazard ratio or adjusted hazard ratio, the ratio is about 0.85 to 0.87, and there have no difference between these two groups. And we can also saw the same similar result from the cumulative incidence curve. Two lines is twisted together in our observation period. And the log rank test shows no significant difference. And in our sensitivity analysis, we can see that no matter we change the definition of outcome or change the observation period, the result shows that there are no difference between the tofacitinib and TNF inhibitor. So based on our result, we compare with the previous study that pulled the result from clinical trial and some observational study which use the registry database and commercial insurance database. The incidence rate is quite similar to with our results. However, one observational study result which include the Medicare database. This in this database, they have a more elder patient with more comorbidity. So we can find that the incidence rate, no matter in tofacitinib or TNF inhibitor, is a little bit higher than the other results. And based on the previous study, we found that they have a signal of tofacitinib use in spontaneous reports results. However, in our observational study and the other one conducted in the US, we found that they have no difference between tofacitinib and TNF inhibitor. So we think that in a real world situation, the tofacitinib patient will not increase the risk of VTE in RA patient. And they have some limitation that because we use the claim database and we do not have the information about the RA disease severity, such as the lab data or So, but we try our best to use the active comparator and gradient match to let the two groups is more similar to each other. And even we use our nationwide database to do our analysis, the events number is quite small. And so it is hard for us to do the further study, such as to subgroup our population. Our strength is that we use the nationwide population is include about 25 million patients, total patient in Taiwan, and it is quite a large kind database. And the RA diagnosis in our study have a higher validity because every patient who want to use B or TSD marks, and they need to be confirmed the diagnosis by an independent second specialist. So the validity validity of the diagnosis is quite high. So in conclusions, the incidence of the VTE in Taiwanese RA patient who use tofacitinib or TNF inhibitor is quite similar with the previous study from clinical trials or observational study. And so in this real world situation, the risk of VTE will not be triggered after receiving tofacitinib in Asian population. So I have to thank our all members in health outcome research centers in National Cheng Kung University. Without them, I don't have this kind of opportunity to do such a study. And thank you for listening, and any question are welcome.
Thank you, Stephen. This is great presentation. There one question from Q&A chat. And could you share your thoughts on why the hazard ratio flipped from 0.8 in the main analysis to 1.3 in the sensitivity analysis? Could you please?
Okay. You mean that after we change our observation period, the point estimate is changed, right?
Yeah, yes.
Okay. Oh, okay, so sorry. So I think that actually even we have think about that because after we change our observation period, the patient includes after the 2014 is quite more severe patient in our population. So actually, we are considering about maybe this is also a little bit related to the disease severity. That's maybe the higher higher severity patient may have related to the higher risk of VTE, and we are considering that maybe this is about a little bit about related to this reason that and maybe have some a little bit interaction. We are still thinking about that, so we do not have the confirmed explanation about that.
Oh, thank you. And Teresa also asked, patients who receive first-line TNF-alpha inhibitor or tofacitinib differ by variables not captured in the data set. At least in Europe, around 19% of patients receive TNF inhibitor as first line. So so the tofacitinib users who receive as first line may be very special group. Thus, it may be difficult to find comparable studies. So maybe is this different prescribing behavior in Taiwan?
So it means that the because of maybe it's related to the one is for injection and one is for oral taking, so it's a little bit different by using. So so they have many difficulty to compare with each other. Is that right?
Yeah,
the question
right.
is about it. In my mind that yes, this is a question, this is a problem about this kind of medication because they have a little bit different. One is oral, one is for injection. And the most concern about that is maybe the different use of this medication will influence the adherence or the persistence. So in the result I presented here is just for the ITT result. We are conducting the study by protocol method, and we also want to figure out maybe whether the different adherence or the persistence between these two groups. And find out whether it will influence our results in our result. So I think that now I cannot directly answer this question, but we are trying our best to do this to consider this question in the future.
The last questions. Dr. Desai asked, do you have any plan to look at other cardiovascular events such as MI or stroke?
Okay, because I focus on this VTE directly due to the FDA warnings, but we have a plan to have a collaborate with other country because actually the event in Taiwan is quite small. So we have a collaboration with other countries, and they also considering about the CV events. So in the future, we will do that.
Okay, thank you, Stephen.
Could I just ask one more quick question? And if you're going to do that collaborative work, will you have plans to subset your data on greater than 65 so that you can get a sense of how it does compare to that Medicare?
I'm sorry that you mean that I can subgroup analysis by the age or something like that?
Yes, because the Medicare data in the US, of course, is in the older population.
Yeah.
So if you subset your data for those greater than 65, you might get a better sense of how your results compare to that study.
Okay, I think that is a good point that we can go to find out some information from it. But if we have a collaboration with the Western database, I think we will consider in that. But actually, the members we have collaborate is based on Asian, and the database here is quite a little smaller than the Western country. So I think that we may not do that in Asian data analysis. But I think this is a good question because actually in now the recommendation is that the patient if have a higher risk of CVD or elder patients, they have a concern about VTE risk when we use this medication.
Thank you, Stephen. Thank you again.
Thank you.
We will move on the next presenter, Dr. Dawas from University of Pennsylvania. And Dr. Dawas, please prepare. Please share your slide. Dr. Dawas will present about the safety endpoint regarding the diabetes medication. Please.
Well, thank you for the introduction. And so I'm going to be discussing today SGLT2 inhibitors and the risk of diabetic ketoacidosis in patients with type 2 diabetes. These are our disclosures. So just a little bit of a background on the topic. As you all know, SGLT2 inhibitors as an add-on to metformin therapy are increasingly used for the treatment of type 2 diabetes. The class protects against major cardiovascular diseases, heart failure, and exhibits metabolic benefits. However, concerns emerged recently regarding their association with increased risk of adverse drug events, including diabetic ketoacidosis. This safety signal started as case report in the medical literature and FDA adverse drug events reporting system. We have also some data from post-hoc analysis of randomized clinical trials. For example, in the Credence trial, the rate of diabetic ketoacidosis was higher in the canagliflozin than in the placebo group. Similarly, in the Declare-TIMI trial, diabetic ketoacidosis was more common with dapagliflozin compared to placebo. So as you all know, these post-hoc analyses of randomized clinical trials are underpowered to make definitive conclusions. So in this study, we aim to examine the risk of diabetic ketoacidosis with SGLT2 inhibitors versus DPPP4 inhibitors and versus sulfonylurea. Both are commonly used second-line classes for the treatment of type 2 diabetes. So this was a retrospective new user cohort study using data from Optum, a commercial database in the United States. And the patient in the study included adults taking SGLT2 inhibitors, DPP4 inhibitor, or sulfonylureas, who had diagnosis of type 2 diabetes within the 1 year preceding their first prescription. Patients were excluded if they had end-stage renal disease, type 1 diabetes, diabetic ketoacidosis at baseline. We also excluded users of combined products that constituted SGLT2 inhibitors and DPP4 inhibitors, and this applied to cohort 1 only. So as you can see here, we had a 2 pairwise comparison. In the first one, we compared new users of SGLT2 inhibitors to new users of DPP4 inhibitors. So this was cohort 1. And in the second cohort, we compared SGLT2 inhibitors to new users of sulfonylurea. So we required patients to have 12 months of continuous enrollment in medical and pharmacy benefits prior to treatment initiation. And this period was used to define baseline covariates, apply exclusion criteria, and examine prior drug use. The study start date was January 1st, 2013, and the study end date was June 30th, 2019. we followed patients from treatment initiation or cohort entry date until the occurrence of the earliest of the following censoring criteria: an outcome of interest, discontinuation of index medication, start of the study comparator, end of enrollment, or end of the study period. So the primary study outcome was diabetic ketoacidosis presenting on hospital admission, primary position only. And we adjusted for a large number of confounders, including demographics, comorbidities, medications, and several measures of healthcare utilization in order to account for differences in baseline characteristics and disease risk factors. We matched patients in each pairwise comparison based on propensity score using one-to-one matching. After matching, we use Cox proportional hazard models to estimate the hazard ratios and the corresponding confidence intervals. We conducted several sensitivity and subgroup analysis to examine the robustness of the study findings, including comparing laboratory values in a subset of the cohort with complete lab values. So we'll start with a flow diagram of the study population. So what you can see here is that we started with around 364,000 patients in the SGLT2 inhibitors and DPP4 inhibitors comparison, and around 444,000 in the SGLT2 sulfonylurea comparison. After applying inclusion and exclusion criteria in the matched cohort, we had 85,125 SGLT2 inhibitors users and a similar number in the DPP4 inhibitors group. In the second comparison, we had 72,436 patients in the SGLT2 inhibitors group and a similar number in the sulfonylurea group. So the figure here shows the distribution of propensity score among new users of SGLT2 inhibitors and DPP4 inhibitors before matching. So this is in the first cohort, and this is in the second cohort, comparing SGLT2 inhibitors to new users of sulfonylurea. So moving to table 1, so we included in the slide here only a selected number of variables that we originally included in the propensity score model. So briefly, in cohort 1, the mean age prior to matching was 60 to 68 years of age. About 52 to 57% of patients were male, and patients mostly had education level less than bachelor degree and were more likely to be white. I will also highlight a few of the baseline comorbidities. So in general, in cohort 1, users of SGLT2 inhibitors tended to have a lower prevalence of heart failure, hypertension, and hyperlipidemia. Also, they had a lower prevalence of a diabetes comorbidity score of more than 2, suggesting an advanced stage of diabetes. Moving to cohort 2, similarly, the mean age prior to matching was 59 to 66 years of age. About 55 to 56% of patients were male, and patients mostly had education level less than bachelor degree and were more likely to be white. Patients in the SGLT2 inhibitors group had a lower prevalence of heart failure, but a higher prevalence of hypertension and hyperlipidemia compared to those in the sulfonylurea group. This is the distribution of propensity score after matching in cohort 1 and cohort 2. So after matching or one-to-one matching, we can see here that all baseline demographics, comorbidities, prior medication use were all well balanced as indicated by the standardized differences. If you look at the here at the column here, all the standardized mean differences less than 0.1 suggest that we have an adequate balance between the two groups in each pairwise comparison. So I'll skip to the primary findings. So these are the main results of the study. So as you can see here, after propensity score matching and Cox proportional hazard model, the use of SGLT2 inhibitors was associated with a higher rate of diabetic ketoacidosis compared to DPP4 inhibitors. Similarly, the use of SGLT2 inhibitors was associated with a higher rate of diabetic ketoacidosis compared to sulfonylurea. The result remained consistent when we compared canagliflozin, dapagliflozin, and empagliflozin to DPP4 inhibitors or to sulfonylurea. However, some of the confidence interval here crossed the null, and this is likely due to the lack of power. We did several sensitivity and subgroup analysis, including increasing the permissible grace period between refills from 30 days to 60 days and 90 days, trimming the tail of propensity score and using propensity score adjustment instead of matching, for which the study results remained consistent across all of these sensitivity analyses. We also assessed for the presence of effect modification within age groups, prior insulin use, stroke, and the presence of peripheral vascular disease. And we can see all the p-value for interaction did not reach the threshold for statistical significance. And finally, we compared laboratory variables in both cohorts in a subset of the primary cohorts only. So in the first few rows here, we can see this is cohort 1, here we have cohort 2, and we selected several lab measures, including cholesterol level, hemoglobin A1C, AST, ALT, and triglyceride level. And interestingly, despite not including all of these variables in the propensity score model, if you look in the post-matching cohort, all of the standardized differences were less than 0.1, suggesting that all of those variables were well balanced, again, despite not including them in the original model. So moving to discussion, several mechanisms can explain the association between SGLT2 inhibitors and diabetic ketoacidosis. For example, some studies suggested that SGLT2 inhibitors may indirectly enhance ketone bodies level in the plasma by reducing sodium reabsorption, enhancing glucose, urea production, and renal ketone reabsorption. A randomized clinical trial found that dapagliflozin versus placebo caused a 16% decline in glucose oxidation and a 14% increase in lipid oxidation. This increase in glucagon to insulin ratio was found to stimulate ketone production. And finally, another study suggested that SGLT2 inhibitors might reduce renal tubular clearance of ketone bodies through a potential effect on the glomerular filtration rate. There were a few observational analyses that compared the rate of diabetic ketoacidosis with SGLT2 inhibitors. One study found a twofold increase in the rate of diabetic ketoacidosis, but the study did not adjust for several of the important baseline measures, including, for example, the use of medication other than diabetes drug. Another study found no association between SGLT2 inhibitors versus other glucose-lowering drugs and diabetic ketoacidosis. However, the study included insulin in the comparator group, and we know that often users of insulin are at advanced stage of their diabetes. The same study omitted the adjustment of important variables such as prior medication use, baseline comorbidities, and measures of healthcare utilization. So finally, unlike the findings reported in a recent analysis, our subgroup analysis showed an absence of effect modification by prior insulin use. So the study has several strengths and limitations. We had missing data on lifestyle variables such as smoking, body mass index, and disease severity. However, we adjusted for adapted diabetes complication severity index to minimize the differences in diabetes complication and severity in each pairwise comparison. We had lab values only for a small subset of the cohort. However, we showed that despite not including those laboratory values within the PS model, those variables were well balanced after matching. And there is the potential for outcome misclassification since we relied on international classification for ICD-9 codes, ICD-9 and ICD-10 codes only. So in conclusion, in this comparative safety study using real-world data, patients with type 2 diabetes who were newly prescribed SGLT2 inhibitors had a higher rate of diabetic ketoacidosis compared to DPP-4 inhibitors and sulfonylurea. And this is conclude my presentation. I'll be very happy to take any questions. Thank you.
Anyone that has any questions can post them in the chat or the Q&A, either one. I had a similar question that you actually answered about the pairwise comparisons and would suggest I can send you the citation, but which is it suggests you look at the article I mentioned before, the Lopez and Gutman article.
Thank you.
I can send that to you through the chat.
Sure. Thank you.
Any other questions?
I have one question. Your results seems very consistent among all kinds of SGLT2 inhibitors. So is there any regulatory action such as safety communication by this observational study?
Is the question, is there a safety communication regarding diabetic ketoacidosis? Is that correct?
Yeah, right, yeah.
Yeah, there is a safety communication by the FDA and by the European Agency of Medicine regarding the safety signal. And there were, I think so far, 2 to 3 observational analyses that confirmed that there is a higher rate, but according to the FDA website, it's still, there is no final decision has been made on this safety signal.
Oh, okay, thank you.
Thank you.
So I think we can move on to our last speaker, last but certainly not least, and that is Dr. Simone Bastrup Isbelson from Denmark, and she will be speaking on comparable COVID-19 outcomes with current use of GLP-1 receptor agonists, DPP-4 inhibitors, or SGLT2 inhibitors among patients with diabetes who tested positive for SARS-CoV-2. So if you could unshare your screen, Gautier. There we go. Please go ahead.
Okay, so can you see my screen?
Yes, we can.
Perfect. Okay, so good afternoon, everyone. My name is Simone Bastrup Isbelson. I'm a MD and a PhD fellow at the Department of Infectious Diseases at Hvidovre Hospital in Copenhagen, Denmark. And thank you for the introduction. So, and also thank you the organizers for giving me the chance to present our work. Okay, so first a little bit about the rationale for performing this study. So we know that diabetes is associated with poor outcomes and around a 2-fold increased risk of mortality in patients with COVID-19. Meanwhile, glucose-lowering drugs, glucagon-like peptide-1 receptor agonists, the GLP-1RA, and dipeptidyl peptidase 4 inhibitors, the DPP-4I, could possibly have a beneficial effect due to their anti-inflammatory properties. A study conducted early in the pandemic showed that sitagliptin, a DPP-4I, was associated with reduced mortality in patients with diabetes and COVID-19 when administered at admission. So we wanted to test this hypothesis that these glucose-lowering drugs could alleviate the course for patients with COVID-19 and diabetes. So what we did was we conducted a nationwide registry-based study with in Denmark, and in Denmark we have this unique personal identifier number that can facilitate linkage between individual level data between the healthcare registries we have available. So we defined our study cohort using data from the Danish microbiology database, where we have test results for the SARS coronavirus 2 RNA tests, and also the sampling dates, and also through the data from the Danish National Prescription Registries, where we have data on filled drug prescriptions. In addition, we retrieved data from the Danish civil registration system, where we have data on age, sex, and date of death. And finally, we obtained data from the Danish National Patient Registry, where we have data on diagnosis codes, hospital admissions, and procedures during hospitalization. So we identified all SARS coronavirus 2 RNA positive individuals in the study period between the 27th of February and 1st of November 2020, arriving at a total number of approximately 49,000 cases. And of these, we then found all the individuals with current use of any type of glucose-lowering drugs. And the current use we defined as having redeemed a prescription within the 90 days before the positive test. So we chose this active comparator design where our exposures of interest were the two groups GLP-1RA and the DPP-4I users. And as an active comparator, we chose the SGLT2I, so the sodium glucose cotransporter 2 inhibitors, in order to reduce confining by indication. We excluded individuals on combination therapies. So if you look at the outcomes, we had the primary outcome was 30-day mortality, and our secondary outcomes were hospital admission, intensive care unit admission, and mechanical ventilation. And all individuals were followed up for up to 30 days. So as our effect measure, we had relative risks with 95 confidence intervals, and to control for confounding, we computed propensity scores of drug exposure based on age, sex, other diabetes treatment, markers of diabetes severity, comorbidities, and use of cardiovascular medicine. So we used the propensity scores to calculate inverse probability of treatment weights, and then we quantified the differences in risk factors by standardized mean differences. So if we take a look at the patient characteristics, then we have our two pairwise comparisons with GLP-1RA and SGLT2I users, and DPP-4I users and SGLT2I users. So in this table, we have both the crude data in the first column and then the weighted data in the second column. And if we look at the crude data, then we can see that the groups differ to some extent. So if we look at the median age, it's 59 in both GLP-1RA and SGLT2I versus 67 in the DPP-4I users. And if we look at comorbidities, then we can see that the proportion of patients having 3 or more comorbidities according to the Charlson's comorbidity index were about 5 to 6% in GLP-1RA and SGLT2I versus almost 9% in DPP-4I users. So after we've made the pseudopopulation with the weighted methods, then we could see that our standardized mean differences were reduced significantly, and we had no weights above 10 after stabilization. So if you move on to look at the COVID-19 outcomes, then this table again presents the two pairwise comparisons, and we have here both the crude and the adjusted estimates. So if we focus on the weighted analysis, then we can see that the risk of death in GLP-1RA and SGLT2I were around 3.5%, whereas the risk of death within 30 days in the DPP-4I group was 8.6%. This corresponds to an adjusted relative risk for the GLP-1RA at 0.89 and for the SGLT2I at 2.42. If we look at our secondary outcomes, then we can see that both the GLP-1RA and the DPP-4I groups were associated with, or the use of them were associated with increased risk of both hospital admission and mechanical ventilation. But if we look at the confidence intervals, we can see that there is a fair amount of statistical imprecision here. So when considering the strengths and limitations of the study, the strengths are that we have nationwide data and we have a complete follow-up on all individuals. When we look at the limitations, then we have a limited sample size due to, fortunately, a low infection numbers in Denmark. And the choice of SGLT2I as a comparator were, of course, to reduce confounded by indication, but we know that these three groups, of course, don't have exact identical indications, so there could be a remaining bias here, although we try to adjust for the factors used when you prescribe these medications. There could be residual confounding that could influence our results from unknown or unmeasured confounders, and they could be driven by maybe more comorbidities in the DPP4I users. So to conclude, the use of GLP-1RA or DPP4I was not associated with improved COVID-19 outcomes when we compared to the SGLT2I users, as we otherwise hypothesized. Rather, we found that the use of DPP4I before infection with SARS coronavirus 2 might have a harmful effect. However, this result should be interpreted cautiously due to the study limitations, including the limited sample size. So at the end, I would like to thank my collaborators, Anton Potpourri from the University of Southern Denmark, Reimer Thomsen from the Aarhus University Hospital, Sten Maswell and Thomas Benfield from Hvidovre Hospital. And then I would like to thank you all very much for listening, and I'm happy to answer any questions. Thank you.
Thank you very much for a nice presentation. I'll kick off the questions. Please do post your questions in the chat or the Q&A. Do you plan to repeat this when you get maybe a larger sample size?
We haven't planned to repeat it actually, but we updated a couple of times because we had a lot of more infections in the second wave in the autumn. But actually, I took a new look at the literature, and I can see that there has been a lot of new studies out there, and especially a large UK study actually finding some of the same things. So I think there is more literature out there already.
Okay.
Yeah.
And did you take a look at the whether you had any extreme weights with the IPTW that might be influencing the analysis?
As I recall, I don't think that we had any problems with any extreme weights. That as I recall, that it was a big problem. Oh.
Okay. Any other questions from the attendees or from Judy? Yeah, here's one. A nice presentation. Why did you choose SGLT2 as comparator instead of sulfonylurea?
So thank you for that question, and that's a really good question. I think that's one of the main questions, which comparator to choose, and we discussed this, of course, a lot. But I think that we ended up with SGLT2I because they were, in general, they're prescribed for the most similar indications as the exposures of interest. And we had actually data from another previous study in Denmark where they have where they saw that actually GLP-1RA and SGLT2I users are quite comparable. So we relied on that data as well for choosing that comparator.
Okay. I think we're at the end. I'd like to, first of all, thank the speakers for excellent presentations and the attendees for attending. And to remind everyone that the presentations were recorded and will be available after the meeting. And thank you, Judy, for co-moderating.
Yeah, thank you, Cindy. Thank you, everybody.
Everyone.